And the connection to primary care is key, and it makes a real difference to people. And sometimes it's hard work to get to that stage, and it's one where health professionals have a role, but they're not the only people involved. Obviously, the individuals themselves, peers are very important, family members, friends, even volunteers can get involved in helping get more people registered in an area. If we know there's an area of high need, people with high health needs but low GP registration, then you can work on projects around that. And there's some very good ones, for example, where people who have been homeless and got support for their health care have then supported other homeless people to get registered with their GPs. But when health professionals do see people, they need to understand then that they might have come through a long journey already, even to get to the door, in terms of mentally their own experience of what they wanted from healthcare, their own barriers and things like that. They've overcome quite a lot to even get there. So the service, when it's there, it needs to be welcoming and accepting of people to begin with. So there's a lot of barriers as well facing people from their circumstances and facing children in this country at the moment. There's 3,000 children every year coming to the UK who are fleeing from conflict, and they're coming on their own. This is without adults. There's 3,000 children. There's 15,000 children who are under 2 and homeless, so infants and toddlers living in homeless situations. NSPCC wrote a recent report, which is well worth looking up, and they've made some recommendations about government action, housing action, and also health services action on this. There's 22,000 identified in the survey, and we think a lot more, identified with Gypsy and traveller ethnicities, ethnic minorities. And in and of itself, obviously not a marginalisation, but when you consider around some of those communities, there's about 40% GP registration rates. We know a lot of them aren't accessing the healthcare they need. Nearly 70,000 children in care, and you'll be well attuned to the ground in your area on whether those figures are going up or down in your area. I assume they have been going up, so they're probably going up where you are as well. We've got 700,000 young carers as well, which isn't on this graph. But I'm thinking about that some of these children interact and cross these boundaries, so it's not like these are set groups. As you know, there's a lot of children facing a lot of complex and different challenges. There's 200,000 children affected by parents in prison, and nearly 1 million living with violence in the home, and 1.6 million in overcrowded temporary or rundown housing, which is an issue we're particularly keen to address with people like Public Health England and the Department of Health. So what does this kind of mean in terms of health professionals, and what does it mean for children's health? Actually, what I wanted to do, I've got some flip chart, a bit of interaction, is what you feel like some of these circumstances might mean for a child's health, and whether we can just like shout out a word, what kind of health conditions might it cause, whether you've got any ideas or experience around that. So, I mean, there's loads we could get into, but this is like just a selection, and it links really well to what I'm kind of saying later on. But as child health professionals, there's a lot in here that kind of you can work around with families to support them with. So there is kind of positive news in that there's work that can be done. So what we wanted to do is find out more about how our services working for people who are homeless or people who are vulnerable in the UK. So we went on a journey really. We travelled around. We talked to patients. The top here is a young homeless man who's now part of the Youth Homeless Parliament, and he does kind of action and campaigning around it. And we talked to him, and we talked to his peers around what it was like for them growing up, and what their experiences were, and what their health experiences were. We talked to nurses around the country in different settings. So we visited all kinds of settings, we shadowed their work, we found out what they do. This is Jane Gray, who's one of our Queen's nurses, and she set up a service in Leicester called Inclusion Healthcare, all focused around providing healthcare for the homeless across Leicester. So she started that kind of from scratch, really. So basically identifying the need of the local area and working around that. And yeah, so I got this because I wanted to read a quote. We were in Leicester as well, and we were shadowing a health visitor for homeless families. And we went around and saw the circumstances that families were living with, and the work of health visitors who specialise in homeless families, because it's a growing field, sadly. But she said, homeless families rarely access group settings such as local children's centre. And so children miss out on critical development, for example in speech and language. And we talked about some of the developmental delay already. Without the support, children invariably start school significantly behind their peers, which affects their confidence and their ability to learn. So what she did is she worked with the Trust, she worked with the hostel, and she worked with multi-agencies, and they ensured that the Let's Get Talking programme for addressing speech and language was brought to those group of families, and that had the significant impact of bringing them up a developmental stage in speech and language. So it was it was identifying a need, tailoring an intervention, and bringing it directly to the families. So yeah, and other areas have done some interesting stuff as well. So when we searched around and when we travelled around Blackpool, they did a programme on data, because they said in our area we know there's a lot of homeless people, but our numbers are like 10 a week or something. We know there's a lot more than that. We can't reach them. So what they did is they improved the data capture between different agencies. And so the community health professionals and the housing link together much more in their data. And they're able to now pick up, like, in kind of real time, if you like, as someone comes in and declares they've got a problem for housing, they're immediately referred through to community health as well. So even if they're not allocated housing, they're able to get support from community health as well. So that's driven the numbers right up. So, and they know now more who that hidden homeless group is, people staying with friends, on sofas, that kind of thing, people in overcrowded housing, and those kind of issues. In Camden, the health visiting service they linked with the Nana Freud Centre, which is a charity, and they noticed their area, they had a lot of mums suffering from mental health problems. They had mums whose English wasn't the first language as well. They did a lot of work on the top here, they did a lot of work around attachment and mental health. So working with the mums around their own mental health, but working as well on their bonding, because when their mental health was poor, their bonding was poor as well. And that improved things a lot in that area. So just by doing that multi-agency intervention, they were able to help the families have overall health. Two others, which weren't directly in the field of homelessness, but they did interest us a lot. There was the Club Drug Clinic in London, and they were specifically set up because they noticed in that area of London there was a lot of use of different substances. And the way they noticed this was they set up urinals in a park, which basically they then tested for. They did a urine analysis of. I don't know about the efficacy of it or whatever, but they did that, and they found there were like 600 substances or something, and loads that they didn't know about even, and they weren't in the traditional drug services. It was nothing like what they were treating for, and they said we just weren't equipped to deal with those. So they learned about the new substances. They identified where people were using them, which was like the local clubs, And then in the local clubs, they made very ready access services. So you could have a QR code in the club, you can scan, make an appointment, you don't need to put your name in, you go into the service, get your treatment or whatever, and it's just a very easy access service that's just responded to the need in that area with that particular class of drugs. Dean Street, which you might have heard about if you're into HIV services, is the biggest HIV testing service in Europe. That's in Soho, and that's a big gay area in London where they've got particular issues around it, and that's why they're particularly keen on it. So they've again looked at what the needs were in that particular area, and they've sped up their HIV testing and their outreach services and made it easy access. And also the speed of the tests, so it's not just a lot of tests, they do like a very quick results service as well. Because no one wants to wait around to find out that. So yeah, I mean, we got very brief insight during our journey into what life was like in those for those families, and how healthcare was being delivered. This was what a health visitor told us as well. She said it's a terrifying experience. It's not a normal experience, and it creates anxiety. Most families we see are suffering from depression. She was talking about homeless families, or families going through the homeless stage. We met one family who the mother was in pieces really, because she didn't want to be where she was, and she left an area a long way away in the country because she'd basically got there to flee an abusive family and friends situation, and now she was being sent back because of the local connection rule, which said she had no local connection in that area. So she had to come back to an area where she knew her family were and they had been abusive to her before. And she was scared to go out, and fearful to even go out into the centre of town and make friends and put roots down there. But because of the homelessness rules, that was where she could get a house. So it was all those kind of things that we were seeing, and it did lead to poor, obviously, mental health in that case. And these are a couple of quotes directly. If you read Shelter, if you're interested about homelessness and children, it'd be worth looking on the Shelter website. They've produced 3 really good reports on homelessness and how it affects children. One from the point of view of children by talking to them. And here's what children said directly. I'm just going to leave them for you to read. There's a couple of them, a couple of quotes on what children said. So again, it goes back to all the issues around providing kind of stability, attachment, all the issues you're trying to, and good health and well-being for children, which we're all trying to nurture. But if parents aren't able to care for themselves because their situations are so difficult, because they keep getting disrupted, then it makes it much harder to build those links. We talk to patients and we talk to professionals as well, and we read the research around what others have done in that area as well. And from that we identified 8 focal points of what patients actually wanted from their healthcare, just to see if there was a difference between what's being provided and what people want from the service. And what came back is they were really keen that doctors or GPs or any health professional, that they were able to choose like what gender the specialist was. So this was particularly important for refugee women, but it did come out in all sorts of conversations with all sorts of groups, different ages, young and old, were very keen that they could choose whether they saw a man or a woman. They wanted to be more involved in kind of the choices in their care. They didn't want to just turn up and have a doctor like tell them what's wrong with them and what needed to be done. They wanted to kind of to be actively involved, even if they were in a tough situation. We want more choices, because choices have been taken away from us our whole lives. I mean, this was what they were saying. Here's a chance to kind of empower us. They also wanted to speak in the language that they use. So that was both when we spoke with people from abroad, that was getting individual interpreters, independent interpreters as well, so not using family members and things. But it was also about jargon and health jargon, and speaking to people on their level and using language that they'd understand and could relate to. That was really important and something that was really struck home in the research. And the time issue was one, and some services have got around this issue. So obviously the 12-minute appointment slot or whatever you get in your trust, but other services like that, I think it was at this Inclusion Healthcare, they have an hour-long stretch for a psychology assessment appointment. They have free clinics, set up times, and they're able to spend more time because they know the people with more complex needs are going to need more time. So, and that's what they needed. They wanted the time to build trust with people. They might not have had time to build trust with themselves over their life or have the skills to do it. So it's a long journey to then build trust with someone else. And you can't just go in and say, you need to do this, this and this. Okay, here's your prescription, go, and expect it to happen. They wanted the service to be values-led and welcoming, and them to know that. So there's consistency between everyone they're seeing in the process, and they're all being kind of friendly and approachable and empathetic to them, and understanding that not all people are the same, and people have had hard times in their lives, and not feeling judged when they walk through the door.